Hi, I'm Bob Blum. I'm the William H. Gates Senior Professor and Chair of the Department of Population, Family, and Reproductive Health at the Johns Hopkins Bloomberg School of Public Health. And I'm here today with my colleagues, Kristin Mmari and Michele to share with you a bit of the work that we are presenting in this special supplement of the Journal of Adolescent Health. Adolescents comprise 27% of the world's population, and of those, nearly all, 86%, live in low and middle-income countries. As the causes of morbidity and mortality have shifted around the world from being predominantly infectious in origin to being chronic, attention has shifted beyond microbes to the social contexts in which young people live. The well-being of adolescents in vulnerable environments, or better known as the WAVE study, was launched to add to our understandings of the issues and concerns faced by young people who live in some of the world's largest cities. While economic development and urbanization worldwide has generally led to more opportunity, higher education, better access to health care, and lower morbidity and mortality, less is known about the urban adolescents who grow up in impoverished communities. The areas of any city where the urban poor concentrate, because they are the least desirable and the most affordable sections of town. The share of the urban population living in these impoverished communities is substantial and growing, especially in countries with rapid rural to urban migration. By the year 2030, 75% of the industrialized world and 2/3 of low and middle income countries will be living in urban areas. The WAVE study focused specifically on 15 to 19-year-old adolescents growing up in highly impoverished sections in Baltimore, Abadan, Nigeria, Johannesburg, South Africa, New Delhi, in India, and Shanghai in China. The focus was chosen because the team recognized that youth living in these deteriorated urban areas are very vulnerable to health challenges from dirty and crowded physical environments, few education or job opportunities, frequent encounters with violence, crime, and drugs, often dangerous working conditions, and limited health services. The team sought to document these problems systematically and to examine the factors associated with poorer and better health in order to identify potential vectors for improving the well-being of youth. Studying adolescents in these areas of concentrated poverty is challenging. School-based surveys miss too many who are not enrolled. Household surveys can miss those who lack residential stability. Surveillance using these sample frames can therefore miss the adolescents who are the most vulnerable to health problems. In order not to exclude these youth, the most vulnerable youth, the team designed a study using respondent-driven sampling, a strategy that has been used extensively to sample rare or hidden populations, like men who have sex with men, drug users, or sex workers. It has, however, rarely been used with adolescents. The study was undertaken in 2 phases, the first of which was qualitative and included in-depth interviews, focus groups, and a Photo Voices project undertaken at each site. The second was a quantitative study and included over 500 young people from each site. Kristin Mmari will share a bit about phase 1, and Michele will follow and highlight some of the quantitative findings that are the focus of this special edition of the Journal of Adolescent Health. Before turning to Kristin, however, there are a couple of important acknowledgments. The first is that the WAVE study was nested in a larger project the Young Health Program, supported by AstraZeneca. And this work was supported by AstraZeneca. Second, I want to acknowledge my colleague and co-PI of the Hopkins component of the Young Health Program, Freya Sonnenstein. Freya was the PI and the intellectual leader of the WAVE study. Kristin, let me turn it to you.
Great. So one of the first questions we asked to adolescents in phase 1 across each of the sites was the perceived importance of their health. And interesting, across the sites and gender, physical health was just simply not a top priority. And as a consequence, very few adolescents were seeking any kind of healthcare services. That said, adolescents still had concerns about their health. And interestingly, these concerns were really varied across gender lines and in the way they were manifested and discussed in the sites. For example, sexual and reproductive health problems were perceived as the primary health challenge facing adolescent females, but the types of sexual reproductive health problems reported varied by site. So, for example, in Baltimore, Johannesburg, and to a certain extent, Ibadan, sexual reproductive health problems were really discussed in terms of pregnancy, sexual violence, and in Johannesburg, HIV and transactional sex. In contrast, in Shanghai and New Delhi, when sexual and reproductive health problems were discussed, they were really described in terms of more gynecological problems. Among the boys, interesting enough, tobacco, drug, and alcohol consumption was really their top priority across the 5 sites. And then for Baltimore males, and in some cases Johannesburg males, alcohol and drug use resulted in acts of violence. Additionally, another interesting worry that came across was that across all the sites, adolescents were worried about their personal safety. And in Baltimore and Johannesburg, it was actually one of their top concerns. And many stated that they didn't even feel safe within their own homes. So when we asked adolescents across the sites about what the factors they thought influenced their health and their healthcare seeking, the responses could really be grouped into 2 main domains, which was the physical environment and the social environment. Unexpectedly, though, factors within the physical environment were actually the most frequently mentioned across sites, and they were mentioned by both males and females. The most commonly reported aspect of the physical environment was garbage and dirt that seemed to surround their communities, and this was perceived to be directly linked to their poor health by their ability to spread disease. Another commonly cited factor mentioned especially by adolescents in Baltimore, Johannesburg, and to some extent Shanghai was the lack of recreation spaces for adolescents, which was described as creating boredom and in many cases influenced adolescents to engage in negative behaviors such as violence and drugs. One female adolescent in Baltimore even described the lack of activities for females was contributing to an increase in teenage pregnancy. And I quote, "We don't interact with each other enough. Every time you turn around, you're standing in a guy's face or there's a guy you're messing with. So I think there needs to be more activities for women than to just have us go to school, come home, and lay in our bed. There's no activities for us, and it's causing us to reproduce a lot. They just don't understand that." Another aspect of the physical environment that was thought to influence adolescent health was vacant and overcrowding housing, which was mentioned primarily by adolescents in Baltimore and Johannesburg. Again, in both of these sites, several of the adolescents said that the vacant homes were really considered unsafe because these were often the places where crime and drug use were observed. The other major influence to adolescent health that was described by adolescents across the sites was social environment, which we could think of as the support that adolescents receive from their peers or their family or the broader community. But unlike the physical environment, the degree to which the social environment contributed to adolescent health really seemed to be more varied across the sites. So, for example, in Baltimore and Johannesburg, the social environment was limited at the family level and was characterized as adolescents really growing up with any type of parent or adult guidance. This lack of positive adult role model in their lives was also perceived to increase their vulnerability to engaging in more sexual risk behaviors and being more exposed to violence and drugs. Further, this overall lack of positive adult relationships in their lives seemed to contribute to adolescents having this general lack of trust in the formal healthcare system. For several of the males in Baltimore, there was an even additional concern about the fact that they had to ensure their reputation within the community. So seeking healthcare services seemed to conflict with their reputation, as getting help indicated that they were vulnerable. Meanwhile, in Ibadan and New Delhi, the social environment affected adolescents more along gender lines. So in both of these sites, female adolescents were quite restricted from leaving their homes. And as a consequence, their social network among their peers was much more limited compared to their male counterparts, who had more freedom to go as they pleased. They could access the media, meet with their friends. Additionally, this overprotection of the girls in both Ibadan and Delhi also appeared to have a negative influence on their health seeking. So many girls in these sites reported that even though they knew of healthcare facilities that they could seek help, such as for their sexual and reproductive health problems, many would not go simply because they were embarrassed and they didn't want their parents to find out. So as these findings point out, adolescents felt their health and their health-seeking behaviors was really influenced by their physical surroundings, the perception of feeling unsafe in the community, and by their family, either the lack of it or being overprotected. To further point out the relevance of these findings, Michele is now going to talk about phase 2 of the study.
Thanks, Kristin, for the review of the qualitative findings. And now we'll share some of our results from our second phase, wave 2, where we built on those qualitative findings with a cross-sectional quantitative survey. We used a shared methodology across our 5 study settings. And as Bob mentioned, most of the global surveillance with youth uses either school-based or household-based sampling, and this can really overlook our more vulnerable youth who may be unstably housed or without regular school attendance. So to overcome this, we use respondent-driven sampling, or RDS. And this methodology can allow greater reach into marginalized populations. Essentially, it's a chain-based referral method where seeds from the target population serve as initial contact points and facilitate recruitment through study coupons that are then distributed to their peers. So across our 5 sites, we enrolled over 2,300 adolescents aged 15 to 19 years. And many of our participants indeed lacked stable housing or were out of school or had high levels of absenteeism. Our survey covered the same domains of physical, sexual, and mental health, substance use, and also the physical and social environments in which they live. So we'll just share a few of our key findings that highlight the dominant health issues, and of course you can read more in our special supplement. So starting with social capital, building really on these qualitative findings, this is the resources or support that exist within people's relationships. For youth, it exists at a number of levels, right? Family, school, peer groups, neighborhood, or community. For the young men and young women across all of our 5 sites, at least one measure of our social capital was found to be associated with overall self-reported health. We found some really interesting gender differences in these patterns, where social capital was more associated with health among girls than boys. So, for example, some of the associations between good health and family, school, and peer social capital were more common among the girls than the boys. The neighborhood social capital factors were found to be the most significant in their associations with health. So moving on to mental health, and many of you know this is a very critical issue for youth. World Health Organization estimates that about 1/5 of all children and adolescents have mental health disorders or problems, and many of these actually manifest before age 14. So this makes youth a critical point for mental health and for wellness. What we found was that the prevalence of mental disorders varied greatly across our sites, but in general, overall, it was substantially higher than what has been found in other settings, in other studies. And this suggests that young people in vulnerable environments may be particularly susceptible due to many of the issues that you heard about through the qualitative work that Kristin shared. Youth of both genders in Johannesburg has had the highest rates of depression, between 41 and 44%, as well as post-traumatic stress disorder, upwards of 50%. Across all of our sites, we found significant gender differences. Young women generally had higher prevalences relative to the men. So moving on, adolescents, especially those in disadvantaged urban communities, are widely acknowledged to be at increased risk of substance use. Indeed, in our study, substance use through alcohol, cigarettes, marijuana, inhalants, and others was really common. Almost 2/3 of all of our youth reported using at least one substance in their lifetime. When we looked at current or recent use, we actually found a lot of variation across our study sites. For example, alcohol use was as low as 2% in Delhi and as high as 47% in Johannesburg. Violence victimization, again, one of the features of these vulnerable urban environments, and we heard about this a lot in our qualitative work. So here too, in the survey, we found high levels of victimization, and in turn, this was quantitatively linked with some of the broader dimensions of community violence, fear of attack, and perceived lack of safety. Again, corroborating the voices of our youth that we heard in the interviews. And as Kristin mentioned, sexual activity is also a major concern for youth in urban settings. We know that poor social, health, and economic outcomes are associated with early childbearing. And here we saw a wide variation in sexual activity among youth. Those in Baltimore had the highest rates of sexual activity, upwards of 75%, compared with Shanghai and Delhi, where sexual experiences were more rare, especially for women. Sexual experience for this study was associated not only with individual level factors, but additionally with unstable housing, witnessing community violence, and perceiving the community to be unsafe. And finally, we explored gender-based violence, as young women are at high risk for physical and sexual abuse, and there's a lot of concern that urban settings can incubate the attitudes and behaviors that perpetuate intimate partner violence and sexual assault. Here we found that partner violence experiences ranged widely across our sites. Over 1 in 4 ever partnered women in Baltimore, Abadan, and Johannesburg reported past year physical or sexual partner violence. The rates of partnership were actually much lower in Delhi and Shanghai, as we heard from Kristin, and as was the prevalence of abuse lower in these settings. So together, when we think about the findings from our quantitative survey, building on the qualitative research, we see first that research with youth in these marginalized environments, it's possible. We can overcome some of the limitations of school and household-based settings in these situations. And what's more is that the context of urban disadvantage and its severity appears to influence the leading causes of morbidity and mortality among youth globally, spanning physical, sexual, and mental health. And I'll turn it to Bob to summarize our study findings and lead the next steps.
Kristin and Michele, thanks very much. What you've heard just now are some brief glimpses into a few of the findings in terms of social capital, in terms of the physical environment and its effects, and in terms of some of the key issues and findings that we're seeing in countries and in impoverished communities around the world. Look at the special supplement. The 6 articles coupled with the editorial, I think, give you a much, much deeper view of young people, 15 to 19 years of age, in some of the world's most impoverished communities. We have a long way to go to improve the health of young people. Hopefully, with this information, we can begin to address the needs that they see in their neighborhoods. Thank you.